Hey everybody, this is Alan Ho. I'm one of the head and neck surgeons at Cedars-Sinai. I'll be moderating the session with Daria. This is probably our third, fourth, or fifth session of a series of fairly successful webinars. And we have an excellent set of panelists today that I think will shed a lot of insight in terms of preparing for surgery. So hopefully this will be useful to all involved.
Welcome everybody to tonight's webinar, which is co-hosted by American Head and Neck Society and ThyCa. Tonight's topic is preparing for surgery before and after. And it's intended to help you kind of get ready for surgery, learn about recovery time and more. And what's exciting tonight is not only do we have doctors, but we have some survivors with us that are going to share their stories. So first, we're going to let you know a little bit about who we are that's hosting this event. Dr. Ho, why don't you tell us about AHNS, and then I'll let everybody know about ThyCa.
Sounds good. Myself, Dr. Moore, and Dr. Senem are members of the American Head and Neck Society, specifically the endocrine section within the AHNS. We are a group of head and neck surgeons with special expertise and focus on thyroid and parathyroid surgery. We are very committed to improving patient care, research, and education, such as these webinars. And in particular, we're surgeons, but we do a lot of research and push a lot of educational initiatives in the spirit of endocrine surgery.
And ThyCa is the Thyroid Cancer Survivors Association Incorporated. And I'm a part of ThyCa, and so is Julia and Veronica. And we're a nonprofit, and we are totally dedicated to supporting, educating, communicating, anything and everything for thyroid cancer survivors, their families, and their friends. We do have a mission, and that is to educate and support the global thyroid cancer community and invest in research. And we have a vision, and that vision would be a world free of thyroid cancer. So let's start with some introductions. I'll introduce myself, and then I'll pass it over to Julia and Veronica, and then Dr. Ho will introduce himself and pass it over to the doctors. So I'm Daria Gerald. My role tonight is to be a moderator and help facilitate this session. I am a 27-year thyroid cancer survivor. Julia, why don't you tell us about yourself?
Hello, I'm Julia. I am a papillary thyroid cancer survivor as of about a year and a half now. And I'm one of the patient advocates tonight.
All right, Veronica.
Hi everyone, Veronica Scales, she, her pronouns. I am a papillary thyroid cancer survivor, 8 years now. So since August 2015. I'm excited to be here as a patient advocate tonight. Thank you.
Excellent. Great. So I'm Alan Ho. I'm a head and neck surgeon. I've probably been in practice for about 10 years. I've been doing this these sessions as moderating with Daria for a year or two now. And very excited to take part. I have a focus on thyroid and parathyroid surgery as well as head and neck surgery. And I'm very delighted to introduce you to our two surgeons here who bring decades of experience in thyroid and parathyroid surgery. So we'll start with Dr. Moore. Why don't you go ahead and introduce yourself?
Thanks, Dr. Ho and Daria and everybody in the audience. I'm excited to be here, and I think it's great that you run these sessions for patients, and I'm excited to hopefully add some value. My name is Eric Moore. I'm a head and neck surgeon at the Mayo Clinic. Been practicing for 25 years here and run our head and neck division in the Department of ENT.
Great. And why don't you tell us a bit about yourself, Ludovico?
Hello, good night. My name is Ludovico Senen. I've been practicing head and neck surgery and endocrine surgery since 2010. I start my career in another country, in Brazil, and moved to US 5 years ago. And I joined to the Cleveland Clinic Department of Endocrine Surgery. So I'm very happy to be here and see how important it's this initiative.
Very good. Well, welcome everybody. Let me just explain a little bit about how things will flow this evening. We will pose some general questions that are on topic about preparing for surgery before and after to the panelists. Tonight's a little bit different since we have both doctors and patient advocates. When we ask a question to the doctor, you'll see a little stethoscope, and to our patient advocates, you'll see a little butterfly. They will answer the question, but in the meantime, you are totally free out there to submit your own questions into the Q&A box. The chat is disabled, so please use the Q&A. Keep the questions general, avoid personal information, and if similar type questions come in, we may combine them. We'll pose those questions to the panelists. We'll try to get to as many topic-related questions as possible. And please note, this session is being recorded and it'll be available on our YouTube channel very soon. All right, so why don't we dive in? First question for our doctors. Does my diagnosis determine what kind of surgery I may need? Can you help us to understand some of these terms? A total thyroidectomy versus a partial thyroidectomy, and then a thyroidectomy with central neck dissection versus a lateral neck dissection.
Great. Why don't we start at the top with Dr. Moore, just to get us get the ball rolling. If you could explain what these terms might mean.
Sure. So the diagnosis will often determine the extent of surgery, and so there are different types of thyroid carcinoma, the most common type being papillary thyroid carcinoma. But the type of thyroid carcinoma, or even the type of papillary thyroid carcinoma, may determine the extent of the operation. There are more and less aggressive variants of papillary thyroid carcinoma that can sometimes influence how much of the thyroid gland needs to be removed. But basically, total thyroidectomy implies that the entire thyroid gland is going to be removed. Total thyroidectomy is a common surgery for thyroid cancer, but there are many thyroid cancers, both by size and type and extent, that don't require total thyroidectomy for adequate treatment. So a partial or hemithyroidectomy, or half the thyroid, can often be adequate treatment for small and contained and non-spreading thyroid cancers. And so many patients will be told, we're going to start with partial thyroidectomy or hemithyroidectomy and proceed as indicated based on the extent of the tumor. But oftentimes you can predict that from preoperative studies. And then, so Dr. Sinner, you want to talk about thyroidectomy and neck dissection?
Yeah. So when we start to talk about central neck dissection and lateral neck dissection, we need to understand that it doesn't mean it's an advanced disease, because it's very common, especially for papillary thyroid cancer, to spread to the lymph nodes. So a lot of patients, they are very scared on the beginning. Oh, my cancer spread for my lateral neck, my central neck. It doesn't mean that your outcome will be bad. It doesn't mean that we need to do not a little bit extensive surgery, but today, with all our resources that we have, nerve monitor and other devices to help to identify other structures, we can do very safely. But of course, it's more than a total thyroidectomy, and involves sometimes a drain, sometimes one day more in the hospital, or more complications like hypoparathyroidism and basically that.
Excellent. I want to, before we jump further, Daria, I know that a lot of patients will have questions about this, and maybe I could ask Dr. Morgan, because he broached upon it. Sometimes people see different opinions, and they'll be told for their cancer that one doctor will recommend a partial and others will recommend a total. And the truth is, nobody's wrong, and everybody may be correct. I think it has a lot to do with the latitude that our guidelines currently engage or allow for particular cancers. Eric, could you by chance maybe clarify for the audience what that entails?
Yeah, great point, Dr. Ho. So in I'd say a good general rule is that the treatment needs to be individualized to the patient, and you need to have a careful conversation with your surgeon about how much needs to come out, what is your reason for that, and what will the effects of that be for me if we take out this much or leave this much, and what will that mean for me as far as will I need to take thyroid hormone afterwards or not. All those are really important questions to discuss prior to the operation to clarify. There are some guidelines, but they're guidelines. They're not absolute. So the guidelines are if you have a low risk thyroid cancer, typically papillary thyroid cancer, that's less than 4 centimeters, confined to one side of the thyroid gland, and the other side doesn't have worrisome nodules in it, and there aren't lymph nodes that are showing up that look ominous on the preoperative ultrasounds and things like that, that a hemithyroidectomy is a very adequate operation for cure for that disease. But there are so many other nuances that may come into play that will influence that decision, and follow-up care and comfort level with leaving part of the gland behind, and what that will mean for future imaging and blood testing to look for further cancer and things like that. So I think a good thing to take home from this is a really careful discussion with your surgeon about what will be the extent and why. It's a general trend that we've realized over the years that you can preserve a lot of the thyroid gland and still do an adequate thyroid tumor operation, but there are many things that will affect that.
Very well said. What do you think,
Before-
Daria? Should we move on, or
Well,
do the patients have?
Well, just before we jump to the next question, the one thing I wanted to ask, just for clarification, what if I have medullary thyroid cancer,
Yeah.
which I know is less common, but does that point to some kind of a different surgery?
Yeah, so you're bringing up other types of thyroid cancer that you can have that sometimes have a more aggressive behavior or more spread or implications for further treatment. And so most of the partial thyroidectomies are done for well-differentiated thyroid cancer, of which the most common is papillary thyroid carcinoma. Other thyroid carcinomas, follicular thyroid carcinoma, medullary thyroid carcinoma, as you mentioned, undifferentiated thyroid carcinoma, typically have more aggressive behavior and in general are going to require greater extent of thyroidectomy. We could have a pretty long discussion on hemithyroidectomy for very well localized medullary thyroid carcinoma. And again, there are very many nuances to even individual patients with the same thing, but most of the time, the non-well differentiated thyroid carcinomas will require more extent of thyroidectomy.
Awesome. Our patient advocates, Julia and Val, did you want to share what kind of these procedures you had?
So Julia, maybe?
Yes. Hi. So I had a total thyroidectomy and right neck dissection. I remember when I was first speaking with the surgeon, a partial was an option, and we talked about the benefits and drawbacks of doing a partial now, and then the potential of maybe having to do the rest later on. But then I got some biopsy results from the lymph nodes, and then there was less of a choice in the matter. We did the total thyroidectomy and lymph node dissection. So that was my experience with what type of surgery I had.
So Julie, you knew going into the surgery that there was probably lymph node involvement from ultrasound or even biopsy?
Right. So we at first it looked like we were gonna just do the partial, but I didn't love the idea of potentially needing 2 surgeries. So I was gonna go ahead with the total to begin with, but then after we did the pre-op ultrasound, my surgeon decided they looked suspicious enough to warrant a biopsy, and those came back like suspicious or positive shortly before the surgery. So
there are lymph nodes next to the thyroid gland, right along the trachea, the windpipe, right next to the thyroid gland, and that's called the central neck. And those are the most frequent lymph nodes that a thyroid cancer would spread to. And then there are lymph nodes that we sort of think of as the second chain out towards the side of the neck, and those are the lateral neck lymph nodes. But most of the time when people have lymph nodes spread, they're going to end up with a total thyroidectomy to give the option of treating additionally with radioactive iodine, which can sometimes decrease the recurrence or spread of disease. And so that's probably the most common reason when lymph nodes are involved that a total thyroidectomy will be recommended.
Excellent.
Okay.
Maybe Veronica, if you could let us know what your journey was like.
Sure thing. So I also had a full total thyroidectomy, central neck dissection with 99 lymph nodes removed. 33 of them were cancerous. I did not know going into my surgery that it was going to be an 8-hour surgery, or that I had as extensive a disease as we found out afterwards. I ended up having tall cell variant and hobnail features, and you know, and I'm sure we're going to get to this later, but about our treatment as well. And so ended up doing the radioactive iodine as well as external beam radiation. So that was 8 years ago, and I'm doing okay now. But yeah, that was my surgery.
Well, you had the whole spectrum of treatment, and you look great.
Yeah.
I mean, that's fantastic that how well you've been doing so far. That's a lot to break down, but thank you for sharing that.
Yeah, thank you.
Dari, do you want to move on to the next case?
Yeah, I think we'll move on. We do have some questions starting to come in, but and we'll get to them. I want to maybe move us along a little bit more. Okay, so after we know what type of surgery that we'll be having, or that I'll be having, depending on your perspective, can you describe the recovery time frame? Will I need to have to stay overnight in the hospital? Will I have a drain, and for how long? And then when can I get back to work? And what about getting back to exercise?
This speaks a lot to Dr. Moore's comment about individualized treatment. Maybe,
Yeah.
Zainab, you could mention what your philosophy is.
So I will start talking about the drains first. So rarely we use drains now. We don't use drains. So everybody asks about that. And for a standard surgery like a total thyroidectomy or a hemithyroidectomy, I do not use drain anymore. That it's very helpful for the patients. And all of our patients, they stay overnight in the institution, especially because our spectrum of patients, they came from another cities, other states sometimes. So for safety, we prefer them to stay overnight in case of an hematoma or other complications. So I don't know if you use like a outpatient for hemithyroidectomy. Some places they do hemithyroidectomy, and the patient after recovery can go home or stay in the hotel. And the recovery time, so it depends the extent of the surgery. Sometimes it depends the previous conditions of the patient, if it's young, old, or have other disease. But normally, I would say could be 2 weeks to 1 month. Not a full recovery, because we know that for the healing process, we need more time, but it depends your kind of job too. If you work as a desk work, sometimes you can go to work like 2 days after surgery. And exercise, I would say 2 weeks to 1 month to exercise, but or orientation, it's not lift more than 10 pounds for 2 weeks, and the other things you can walk in the treadmill and do other things, but like a light exercise. It's basically our thoughts here. But of course, if you have a lateral neck dissection or you have a drain, you need to have more time to recover.
Great, thanks. I know, Dr. Moore, that the field has changed. It's still changing from when I started to now. What is your practice like when it comes to answering these questions for a standard case?
For hemithyroidectomy, I don't typically put a drain in, and it's usually outpatient surgery. And we'll get into, I think, some of the calcium questions and how that influences inpatient and outpatient management. But I'm going to guess that, you know, Julia and Veronica both had thyroidectomy, but I'm going to guess that their drain management, their recovery time, all those things were quite different because of different extents of surgery. And so, again, it's a really individualized thing. I typically use a drain the more extensive surgery I do. A drain is a tube that comes out of the neck or the incision somewhere, and it basically pulls out blood and serum, which is fluid that kind of comes out of the wound bed and muscles after the operation. That fluid has to go somewhere. So either the body's going to resorb it slowly or the drain's going to pull it out. The more extensive surgery I do, typically the more fluid will be there. So I'll use a drain for things like lateral neck dissection. I use a drain for total thyroidectomy often. And I don't usually use a drain for hemithyroidectomy and less extensive resections. I think recovery also would mirror that. So recovery will be longer or quicker depending on the extent of surgery. Recovery is also a very individual thing that has to do with the patient's overall health and sort of how they react to the anesthetic. And that can be quite variable. When I talk to people about recovery, I use sort of a standard phrase, just like Dr. Sinham said, about 2 weeks, but it might be 3 months for some people, and some people might want to try to go back to work in 5 days. And it can be quite variable how you feel. Most of the wound is pretty well sealed and healed after about 10 days. A lot of the swelling is gone, but that doesn't mean you feel normal at 10 days. You're still going to have effects of surgery that might bother you for months after that, as far as numbness in the skin and changes in the incision and those things. So it depends on what you mean by recovery. As far as exercise, you really want to try to avoid getting your blood pressure up and straining and putting stress on the wound in the perioperative period. So most people can walk soon after the surgery and do light things. But as far as weightlifting, vigorous exercise, contact sports, things like that, you're going to want to wait several weeks so that you don't end up with any untoward parts of the incision or blood under the skin or something like that.
Here's a corollary question, because I know Mayo Clinic and Cleveland Clinic oftentimes see patients from out of state or out of country. When do you allow out of state, out of country patients to fly back home?
Well, it's a really great question. Once you're out of the risk of hematoma is probably a great answer to that question, because it would be horrible to have a person on a plane flying across the ocean and have a hematoma in their neck and have no way to manage that. So once you're out of the risk of hematoma, unfortunately, the risk of hematoma can be a little bit variable too, but I usually wait 5 days.
Yeah, 5 days it's a good time.
Excellent. Okay.
We have a couple of questions that I think might fit here. So one question is a person who has both Hashimoto's and Graves, and also is BRAF positive with V600E, and now is diagnosed with papillary thyroid cancer, and was just curious if these things will affect his or her recovery, and does it mean that the cancer might be harder to treat?
Well, we know the Hashimoto and Graves disease, they are inflammatory disease. So it depends, varies a lot, but sometimes we have some patients with Graves with small inflammatory reactions, and sometimes we have patients with Graves that it's a very difficult surgery. And the fact to have the BRAF mutation, we don't need to do a extensive surgery if the lymph nodes are negative. Probably will be like a standard thyroidectomy because of the mutation, but maybe Graves as a background could make the surgery a little bit more challenging sometimes.
Dr. Moore, have you had much experience with Graves or Hashimoto's cases? I know that sometimes they are a challenge.
Right. So part of the thyroid operation involves separating, or a lot of the thyroid operation involves separating the thyroid from the surrounding structures. And the surrounding structures are muscles that sit over the top of the thyroid gland, commonly called the strap muscles, the windpipe that sits immediately beneath the thyroid gland. And as Dr. Senna mentioned, inflammatory thyroid conditions can cause more scarring of the thyroid to those surrounding structures and make separation of the planes around the thyroid a little bit more tedious and a little bit more difficult. Certainly doesn't mean that the operation can't be done. Might be a little bit more time consuming. I'd say overall for the patient, the end outcome should be very similar to not having those things, but for the surgeon doing it, it may take them a little bit long and they may struggle a little bit more just to get everything freed up and how they want it. Ultimately, though, I don't think the outcome is going to be affected negatively for the patient as far as their overall recovery and how they do. It is true, though, that with those conditions, I probably would not perform partial thyroidectomy in that situation, but if you did, you know, one of the values of partial thyroidectomy, there are some, but is the potential that you may still go on and have functioning thyroid gland afterwards. And in those conditions that were just mentioned, it's unlikely that you're going to be able to predict and have functioning thyroid gland a high percentage of the time with partial thyroidectomy.
Bottom line, I would just add for those conditions that are inflammatory, there's a modestly higher chance of oozing, and it might compel me to have a higher likelihood of leaving a drain in those situations. To kind of sum up what I would say in those particular circumstances. Of course, each is individual.
And then there's a question about the term dissection. Is a dissection only indicated with cancer, or if it was just like Hashimoto's that you were dealing with, would you still do a dissection?
So
No.
there's a few different terms there, but to a surgeon, dissection is pretty much the act of operating. But the neck dissection that we're talking about is the act of removing lymph nodes from the neck, either in that central part or lateral part. And the neck lymph node removal would just be dictated by preoperative imaging and extent of thyroid tumor, not those other conditions.
Okay, awesome. All right, let's move along. Just a reminder to our survivors and caregivers out there, feel free to ask questions. We will get to them, as you can see. Okay, so getting to kind of the practical side of getting ready for surgery, Julia and Veronica, this is for you. Maybe we can start with Veronica. Do you have any helpful tips or suggestions to prepare for surgery? We see this a lot on social media. People say, I have surgery next week. Anybody out there, can you share your tips and tricks? So what are your tips and tricks, Val?
Yeah, so one of the things that I did before my surgery is I would write down all of my questions, right? To make sure that whenever I was seeing my doctor or talking to the nurse or having a phone call for, pre-op, I would have the questions written down, because there's so much going on in your life before you get ready for surgery that it's so easy to be forgetful and forget things. So for me, writing everything down and having a little notebook that I carried around with me so that I could ask the questions and get the answers to kind of calm my nerves. So that was the biggest thing that I did. And my doctor actually sat down, he said, I see you have a little notebook. Do you want me to answer these questions for you? And I was like, would you? And he was like, absolutely. Let me just answer these questions for you. Just kind of humanizing the process and making it a little less scary for me, because I was by myself at the time in a city where my family was not. And then the second thing I would recommend is, having things to do after you get out of the hospital. So whether it's, and these are like simple things, like making sure you have food in your house, making sure you know what you're going to be watching or who you're going to be calling in case of an emergency. These are things that I think took for granted prior to my surgery, but when I got out of the hospital, I was like, I didn't think about any of these things. And so now I always recommend it, so that if you're going to be alone, or if you have family nearby or friends nearby, you know who you're going to call to kind of keep you company. So yeah.
Awesome. How about Julia? What helpful tips do you have for people heading into surgery?
I think the taking notes is such a big thing because, like Veronica said, you're distracted, overwhelmed before surgery. You just can't remember all the information, even if it makes sense in the moment when your doctor's explaining it to you. Other than that, though, I work as a nurse, so I take care of patients who spend a lot of time in bed or have surgeries themselves, and their hair always gets so matted and messed up in the back. So one of my tips is, if you have long hair like I do, I recommend like braiding it tight in French braids or something before surgery. I feel like it's more out of the way. And I did not feel like taking a shower and washing my hair the day after surgery or even 2 days later. So it was very convenient. And especially your neck feels weird after that type of surgery. I didn't want my hair on it, touching it, brushing my hair felt weird with the drain sticking out. So that was definitely something I found helpful. Um, like I would also, like Veronica was saying, bring a phone charger to the hospital. And if you have a support system like nearby, utilize them. I had to spend only one night in the hospital. And like I said, I work in a hospital. I spent many nights in the hospital working, but on the patient side, it was different. I was very happy to have my mom there. I told her, I'm like, Mom, I don't need you. Like, I know how to spend a night in the hospital. It's literally what I do for work. But just having her there when you're having a tough time sleeping, or you wake up like, does this look funny? Does it look different than it looked 5 minutes ago? Just having someone there to kind of ease those silly concerns you have when you're stressed out, overthinking things. I don't know. Those things were incredibly helpful for me.
Any tips about sleeping position, like for when you get home, when you don't have that adjustable bed?
Oh, I was also going to say the shirts. If you, after surgery, you don't want to be pulling things on and off your head that has like a close neckline. So like button down shirts, if they have a little pocket on the front, you can put your drain in there too. I'm a fan of t-shirts. So I have an example here. I just cut all my t-shirts down the front right there, and it makes the neck nice and wide. So if you don't like button
Nice.
downs, t-shirt slides right over, really easy. That was a savior for me.
I know on Reddit, sleeping position comes up a lot. And one of the things I've read out there is like to use like a in-bed reading pillow to kind of prop yourself up, and even a neck pillow so that you're not flopping all over the place. And I know some people suggest that.
Yes,
All right.
I loved my little bed buddy pillow after surgery, whatever you call them. Like,
those are great tips. Anything else before we move on?
Or if I could ask Julia and Veronica, was there anything that you wished your surgeons had told you? Obviously, they did wonderful jobs that you wish you had known in advance. Just it'd be great to have feedback on our end.
well, one thing that I was not entirely prepared for was how numb my neck would feel for how long afterwards. I figured, my surgeon told me, oh, it'll be numb for a little bit. And I was like, oh, okay, sure. But, a week later, I'm like, it still feels so strange. And I was able in my follow-up appointment to talk to him, and my concerns were addressed. But that was just not something I was prepared for, was how long the numbness was going to last. And for at a certain point, I'm like, is it going to ever feel normal again? Is it going to feel like this forever? But it does back to baseline now. So it did go away, but it did take longer than I originally
How long
thought.
did it take?
I had the drain in for a week, and then I want to say at least like another week or so after that came out, it still felt weird. It was one of the things that I didn't want to go back to work because it was too like distracting. I was like, I can't do anything important with the way my neck feels. Like,
It can take a long time. I think that's an excellent point. It can sometimes take months.
It was fast for you. It was very fast.
I think I went back to work about a month after my surgery, and that's probably when it started to feel, and it still felt a little strange, but I could at least, the tingling went away, and I could feel when I touched it. It just didn't feel totally normal, but it was much more normal feeling than those first like 2.5 weeks.
So there are two things I want to add. I wish that I would have known about, I know we may talk about calcium in a few minutes, but I wish I would have known how important calcium is in this whole surgery process. So I actually was hospitalized for a week. because I was at risk for low calcemia. And my doctor said, we're not sending you home. So I was there for an entire week because my calcium wouldn't come up. And so I had no idea about that. And then also didn't realize that parathyroid and removing them and reimplanting them would have some implications. And so those are two things I wish I would have known prior to the surgery. I actually still have a numbness here. I lost complete feeling over here on the left side because of how, extensive my surgery was. And then, physical therapy was so important for my recovery afterwards. And I did that for about 8 months post thyroidectomy because it was so important.
We have a real practical question that popped in. Is use of a CPAP machine still possible after surgery?
Yes, actually, after we finished the case in our institution, we always say to the patient, hey, bring your own machine to the institution. So during the night, respiratory therapists, they help the patient, and they can use during the same night of the inpatient night, the machine. So there's no problem to use the CPAP.
Good, that's great. Okay, why don't we move along? This is a great, so much wonderful information. If anybody out there wants to share what your experience was like, what kind of thyroid cancer you have been diagnosed with, and whether or not you've had surgery yet, feel free to pop that into the Q&A since we've got the chat disabled, if you want. So for our doctors, again, is it true, perfect timing, perfect segue, is it true that my calcium levels might drop after surgery, and how is that treated?
Let's start with Dr. Moore. This is one of the conundrums of thyroid surgery that is difficult to predict and sometimes difficult to explain for patients, but it happens. We know it's true from Veronica's situation. But Eric, why don't you take us through your thought process with this?
Calcium is an important mineral that we eat in our diet and excrete through urine, and regulates almost every function that you can think of in the body and multiple cells. And so our body is constantly keeping our calcium level at an even level for what it needs. A lot of that is done by 4 small glands that sit behind the thyroid gland. They're called parathyroid glands because they sit next to the thyroid. That's what that means. And there are typically 2 on each side behind the thyroid gland, and they can be intimately up against the surface of the thyroid gland. Those parathyroid glands regulate that homeostasis of calcium. So they are reacting to the body's calcium level, and they will secrete their hormone when the body needs more calcium. And that's a constant, really quick acting, even balance throughout day and night in our lifetime. When we take out the thyroid gland, we can affect the parathyroid glands in a lot of ways. We try not to affect the parathyroid glands in any way when we take out the thyroid gland, and we try to do that by treating them gently and keeping their tiny blood vessels completely flowing so that we don't go into any kind of parathyroid shock where they're not getting enough blood and then they could not function well. But there's sometimes when, even with that careful treatment, that the parathyroid glands won't work perfectly after the operation. The effect of that can be a low parathyroid level. The body's interpreting that by there's plenty of calcium around, and that'll drop our calcium level. And then all those functions that calcium regulates will be affected. That's called temporary low parathyroid level after thyroid surgery. Many people don't get it at all. It's much more common when you do total thyroidectomy than half thyroidectomy, because when you do total, you could affect all 4 of the glands, versus when you remove half the thyroid gland, usually the other 2 are untouched. And like in Val's situation, where you have all of these lymph nodes that have thyroid cancer all around the central neck, around the parathyroid glands, sometimes it can be nearly impossible to keep the parathyroid glands functioning or even keep them in place. And she mentioned reimplantation, which we'll talk about in a minute. But the take-home message is that even with well-done total thyroidectomy, your parathyroid glands can temporarily cease to function normally, and your body's calcium level can drop. And you can start getting symptoms of tingling and numbness as an early sign. And then when it drops a lot, you can actually start getting muscle spasm and all kinds of untoward events. And so you have to supplement the calcium level often after the operation by taking extra calcium tablets. Calcium carbonate, Tums-like tablets are an easy way to supplement the calcium. And if the parathyroid hormone function is really low, you might have to take calcium along with vitamin D, which helps your calcium absorption.
Great. Dr. Senham, let's say your patient is found to have low parathyroid levels. What is your strategy with such patients? Do you have a similar strategy, Dr. Moore, or do you have something simple in mind?
So the morning after surgery, we draw blood and test calcium levels and PTH levels for all patients that undergo to total thyroidectomy or total thyroidectomy with the central neck dissection. And based on those levels, we will decide. Normally, when it's less than 10, the PTH is less than 10, we give calcium for all the patients, and sometimes calcitriol together that Dr. Moore mentioned. It's a more active form of vitamin D that will help to maintain these levels, the normal level of the calcium. But for example, in the morning, if the PTH level it's normal, it's the range of normal, the chance for you to have a hypocalcemia, low calcium after surgery, it's very low. But still could happen.
And can you tell us a little bit more of what Dr. Moore suggested about transplantation? Like, what does that entail? Like, what did Val go through? Mm-hmm.
So because Dr. Moore explained very well, there are tiny vessels that supply the thyroid gland. So sometimes we, even using good technique and be careful, we can't prevent this. So what we do is we remove from the patient this gland, and we chopped the gland in small pieces, and we auto transplant in a muscle here in the neck. But when we do that, it will take some time for this gland start to work again, because she needs to create her own blood vessel to drain the hormone and start to produce that. So it takes some time, maybe 2-3 weeks. We don't know. And so in this time, we normally give we give calcium. But if it's one gland, it's fine, because the patient has the other 3 glands. So it's not a problem. But for example, if you go through a central neck dissection, normally it's easy to take the lower glands, so you will have only 2 glands. And it depends. Sometimes we devascularize one gland, you need to reimplant one, so you have one reimplanted, one that should be working normally, and you can have like a more severe hypocalcemia. And we treat this with sometimes calcium EV or a high dose of oral calcium.
So
Val, do you continue to take calcium?
I take calcium every day and calcitriol.
So in severe cases, sometimes the parathyroid gland function won't ever function normally, and you'll have to supplement and keep that level in homeostasis. Most of the time, as Dr. Senham mentioned, even with one parathyroid gland, they're pretty adaptable, and they'll come back and function adequately, and people will be able to come off calcium, but not always.
Yeah. Are you still taking calcitriol and calcium or no?
I take both.
Okay.
From a practical point of view, Val, I think, do you have to strategize when you take it during the day, especially since Synthroid requires its own,
Yeah.
Mhm.
So I
Talk
take
about
so I take mine mostly in the evening. I do carry petites with me during the day in case my calcium drops low, so I can take it and pop a quick one. They're tiny little pills, calcium pills, and I also have calcitriol like in a little travel case with me at all times too, because the muscle spasms, the cramps, those are all real, and they do happen quite often, and you can feel it.
How can you tell when your calcium's dropping?
Yeah, I start getting muscle twitches. I get muscle cramps. I go numb here in my jaw. I'll go numb in my hands. And so the numbness and the tingling is where I can feel it. And so I've started taking the small amounts of calcium to support that. I try not to take too much calcium, but just enough.
Great. Daria, you want to move on to the next question? Yep.
Yeah, so the next question was actually for Val and Julia. So let's ask Julia. Did your calcium levels drop at all after your surgery, and was it temporary?
So my calcium levels did not drop. I know they were able to keep 2 of the parathyroid glands in place, and then 2 of them, I read the surgical note, it said they minced them and put them back in my neck muscle. I was like, does that mean something different in surgery, or is that the same?
It's the same thing in the kitchen as it does in surgery.
Yeah.
I thought that was an interesting word choice. But the day after surgery, they checked my calcium levels, I think, when I got to the hospital room after surgery, and then the next morning as well. And I didn't have, they kept asking, they stroke your cheeks, they ask if your fingers are numb or tingly, but I didn't have that. They said my calcium levels were good. And I asked if we should continue to follow them, but they said if it was fine at that time, that it wouldn't really be necessary to keep following up on the calcium levels, that it should be good as it was, just maintain that. So mine, luckily, was not an issue.
Awesome. So maybe a quick question from the audience. If you've had a total thyroidectomy, how soon after surgery do you need to start taking a synthetic thyroid hormone?
Okay. That's also a question with a lot of variability in practice. Dr. Moore, do you have, I'll tell you just what I do. We usually start the day after at 6 a.m. And we dose it based on a patient's weight. And a month later, the endocrinologist will recheck the blood and recalibrate the dosage. Dr. Moore, what is your practice like?
Exactly the same, unless for some reason one of the endocrinologists to the patients all wants any kind of different dosing schedule. So we treat our thyroid cancer patients in conjunction, like I'm sure most people do, as a team with an endocrinologist. And if there's any reason that there's going to be a different schedule, then I follow what the endocrinologist wants. But we typically do exactly the same as you do.
Dr. Senem, you as well, or are there other variations of how you practice?
Same thing. Next morning, 6 a.m., patient is receiving the first dose, and we dose the TSH in 6 weeks.
But it is true that across the country that some places will recommend that the patients not start levothyroxine or Synthroid for up to 5 days later. They want the native thyroid hormone to wash out before they begin the medication. So there's a variation in practice for sure. All right, Daria, I guess there's a question 6 now.
Yeah, so what can I expect about my voice after surgery? And simultaneously, we had a question come in. Do you recommend voice therapy? This person uses their voice every day for their job, and they were told that they may experience voice changes.
Excellent question. So we covered. Are you guys getting feedback?
Yeah, we got a little echo with you, Eric. Try again.
A little. You're okay now, I think.
Okay. In addition to the parathyroid calcium issue that we discussed, the other major issue with thyroid surgery is that the nerves that run to the vocal cords run up either side of the windpipe behind the thyroid gland, before they enter the voice box and control the motion of our vocal cords. Our vocal cords open up when we breathe, they tighten up when we speak and sing, and the vocal cord nerves control that motion and function, and they're intimately in play and next to the thyroid gland and seen during thyroid tumor removal and central neck lymph node removal. Usually with thyroid surgery, the vocal cord nerves are undisturbed and the vocal cords move normally after the surgery, but tumor can affect the vocal cord nerves and invade the vocal cord nerves or be stuck to it or be very close to it. The act of removing the thyroid gland can sometimes put tension on the vocal cord nerves, and that can affect the vocal cord nerves. When they're affected, then the vocal cord of the side where the nerve is affected doesn't usually move well, particularly it doesn't swing open during breath and tighten up during speech. It sits in one position and the other functioning vocal cord does all the work, and that can cause changes in the voice and hoarseness. Almost always that's temporary. It will recover with time, as early as several days, but more typically in several weeks if it's affected, but almost always by 2 to 3 months, it will recover. But your voice can be affected while it's recovering and sometimes even after it's recovered.
Excellent.
Another thing can happen to the voice in thyroid surgery, and just the act of putting down an intubation tube and having it sit between the vocal cords can make the vocal cords swell and cause hoarseness. So some people wake up and they have hoarseness and they're worried, oh my gosh, my vocal cords are affected. But that goes away very quickly. That's a swelling of the vocal cords that usually resolves in 24 to 48 hours, and then the voice returns to normal. As far as voice therapy can be super effective for all things that affect the voice. Vocal cord swelling after surgery, problems with the nerve, but I don't typically have everybody who has thyroid surgery go to a speech therapist or do voice therapy. I usually involve them if the people are having trouble with their vocal cord motion after surgery.
Great. And so Dr. Moore has covered the vast majority of situations when it comes to voice. Dr. Senem, there are issues sometimes with the supralaryngeal nerve. Can you describe what that's like for patients on a day-to-day basis? Mm-hmm.
So this is another possible situation. Normally, I like to talk a lot about these nerves and parathyroids with the patients, because when the patient understands well everything, makes everything more easier for everybody. So the superior laryngeal nerve, it's a tiny nerve we call sternal branch of superior laryngeal nerve, and he controls the tension in the vocal cord. So using surgical maneuvers and the nerve monitor, we can safely dissect this nerve. Normally, most of the time, we don't see this nerve because it's very small. But using these kind of maneuvers, and we can preserve this nerve. Our goal is preserve this nerve. But after surgery, if something happened, or if you have an extensive surgery you need to do, or maybe tumor invasion, something like that, you can have some problems after surgery. The most common problem, it's you lose the pitch of the voice, and you see that your voice it's not stronger as was before the surgery. Basically, what happens. So of course we can use some phonotherapy, speech pathologies to help, but it's tough to improve like it was before the surgery.
Got it. Okay. Daria, do you want to? Is this the last question, or did you want to?
No, we have one more. I'll just put a plug that there are some really excellent ThyCa conference videos on voice complications that you can find on our YouTube channel. This is a topic that we could spend the whole hour, on voice. So what will my pain be like, and how will that be managed? And that's actually one of the questions that came in.
Great. Dr. Moore, what is your normal protocol like? I know, again, it's different from surgeon to surgeon.
Typically, post-operatively, we use all the intraoperative anesthetics and after the operation, when patients waking up, we typically use a regimen of Tylenol on a scheduled dosage for pain post-operatively, and we also use Motrin for pain post-operatively. Most thyroidectomy pain, and I'm interested what Julia has to say about this and what Val has to say about this, most thyroidectomy pain we feel like can be managed very well with non-narcotic pain medication, and we use narcotics for breakthrough pain and based on the extent of surgery and the patient's condition, but most of the time non-narcotic Tylenol and scheduled Motrin dosing.
And Dr. Julia and Val, how is your pain managed? Is it in a way similar to what Dr. Moore described?
Yeah, my provider gave me scheduled Tylenol afterwards. He also did prescribe me a small dose of oxycodone, but honestly, my neck was so numb afterwards that nothing really hurt. It just felt weird. And Tylenol didn't really help with that. And to be real, the not pooping was worse than any pain I was having. So I didn't really take much of the oxycodone because I felt like it wasn't really helping. I did keep at it with the Tylenol just in case that was doing something, but my pain was not the most pressing thing for me after surgery, I guess.
I feel like the scheduled dosing helps rather than just waiting for the pain gets uncontrollable and then taking it and expect it to work. So I think the scheduled dosing helps. And I'm glad you said that about the narcotics, because that's the two-edged sword. I mean, narcotics can help with pain, but then you take on all those side effects that you're going to get with it too. And then it's hard to know what's making you the most uncomfortable.
Val?
Unfortunately, I was in the hospital for 7 days after, and so my pain medication was mostly distributed via IV. The strongest one I had to take was Dilaudid. My body did not agree with it at all, and I was very happy that I didn't agree with it because it made me feel so terrible. So really, it was whatever they were giving me was I don't know if it was Tylenol or acetaminophen. I definitely did have some oxycodone as well. But I know the strongest one I had was Dilaudid, and it was not great for me.
And Dr. Senem, any changes in your protocol from what has been already talked about?
We do basically the same thing, because thyroidectomy, of course it's not a painful surgery like others, like an abdominal surgery or a thoracic surgery, but of course pain, it's something very particular and should be individualized. But we do not use opioids. The only thing, I don't know if Dr. Moore used or not, when before close the incision, we use something to numb the incision for 4 or 5 hours, like a local anesthetic, and basically that. But it's Tylenol and Motrin, and most of the time I say, hey, take Tylenol, and if you need add Motrin, it's fine. But most of the patients, they respond very well to Tylenol.
I'm a little behind the times when it's my practice. I would like to emphasize that what Dr. Moore and Dr. Senem are saying is becoming more and more the trend. I still give a little bit of Ultram, which is a narcotic. It's similar to Norco in terms of potency, but it may be a little less likely to cause constipation. So I still give that just almost as a security blanket for the patients, like Dr. Senem says, right, might need a little bit more for their pain.
I use Ultram too. If they somehow some allergy to Motrin, I prefer to use Tramadol, but no oxycodone.
Well, great.
Believe it or not, we're at the end.
All right. Well, all good things must come to an end. So we want to thank
Yes.
Dr. Moore, Dr. Senem, Julia, and Val for a fantastic response to these questions. I think everybody gained quite a bit, not just from the surgeon's perspective, but from the patient experience. I think this is the first time we've done it in some time, and I think we added a lot. What do you think, Daria?
Yeah, this was great. I mean, the tips, the tricks, the just kind of the foundational information, what to expect, it's going to help. This session is going to help so many people. I'm sure it helped the people that tuned in today. But this one's going to live on in YouTube for a long time and get a lot of visibility. So I'm excited. Thank
Thanks
you.
for your
Thank you
questions.
all.
Great questions.
Yeah, thanks for the invitation. It was a great panel.
Thank you for all your responses. And I guess,
Thank you.
Dara, we'll see you and I together come March next year for the next session.
Yeah, we'll figure out that date and get some advertising going out there on social media and Reddit.
Right.
Thanks, everybody.
Thank you, everybody.
Take
Have a
care.
good evening.
Thank you.
Bye-bye.